Welcome to another episode of the Health Hour. I'm Toni Preckwinkle, President of the Cook County Board of Commissioners. We're excited to be with you as we all talk about the most important issues of the day, our personal health, the health of our communities, and our fight against the COVID-19 pandemic. Our guest today is Dr. Gregory Huhn. With over 25 years of experience in the medical field, Dr. Huhn is an infectious disease specialist and serves as associate professor at Rush Medical School. A graduate of Tulane University, Dr. Huhn also serves as senior director of HIV services at Cook County Health. In his role at the county, he's helped spearhead our COVID-19 antibody research efforts while also serving on the front lines as we work to get our public health message out to communities. Dr. Huhn, welcome.
Hey, thank you, Madam President. I'm happy to join you today.
Thank you. I want to allow you an opportunity for our viewers to get to know you. Can you tell us about your background and how you first became interested in public health?
A little bit of a journey. I'm from San Diego. I went to school, University of California at Berkeley, graduated with a molecular biology degree, and then came back down to San Diego to work at Scripps Research Institute. I was a gene jock, basically, for the first couple years.
What is a gene jock?
A gene jock. I did genetic engineering, basically. This
and
was
what
a
is
time.
that?
Yeah. So
what
this
is
was a
that?
time. Sure. This was a time where. Do we remember when we had that concept of test tube babies? Right. There was a time when there was a time when we could actually take genetic material and have it somehow cultivated in. It was called a test tube, but they're basically petri dishes. And then you could grow it to where it could become a human life. And so I was sort of on the bench side of that, where we could actually take genes and put different genes in different pieces and try to figure out if we could make proteins out of those genes, if we could make different factors that could treat diseases from those gene snippets, I guess. So that's where I became a gene jock. And that was my degree, that molecular biology.
Okay. So how did you end up in medical school?
Right. So then I was working in a lab in San Diego and decided to check out a new convention center that had just opened up. This is back in 1990. And just to really kind of go down and spend a weekend to see what was happening in San Diego. And there was a vendor there that I ran into, and he was doing deforestation work in Dominican Republic. It was called Floresta. And I was just interested in what he had to say. And I said, well, I'm interested in some international work. I have some time, actually. And he said, well, I'm not sure for you that that's the right type of work. You come from this, biology background. I actually know a guy who has a network for public health officials, nurses, doctors, lab people in different countries and has jobs for them, volunteer positions. So that was called AmDoc Option. I actually registered through that. I registered through some of my lab skills, and I got some calls from some people at that time, Thai Cambodian border, Nicaragua and Honduran border, some really hot spots. And then I actually got a call from people in Liberia that were looking for somebody to work in their lab, in their hospital.
For our viewers, Liberia is on the west coast of Africa, but go ahead.
That's right, founded by freed American slaves in the early 1800s. That's correct.
Okay.
And at that time, there was an insurgency happening in a different part of the country. It wasn't in the capital where I was working in Monrovia, but eventually it reached the capital. And then I started working with Médecins Sans Frontières, which is at that time the European outfit for Doctors Without Borders. I started a blood bank. This was really because we had a lot of war victims that were coming into our hospital. And that really energized me for the work that I could foresee myself doing, not only in my hometown as I went back to take up my old job, but to as a vision, perhaps globally within public health, within tropical medicine. So I applied to medical school. As you mentioned, I went to Tulane. I got a concurrent degree in Masters of Public Health and Tropical Medicine. And from there, after I did my training in internal medicine at Duke, I worked for the Indian Health Service. So again, Navajo, these are really people that are, you could say, disenfranchised here in the United States, really
marginalized.
Really an important sort of public health goal to ensure health in these populations.
Okay, just a second. So the
sure.
Navajo Nation is in the Four Corners area, which is
That's
Colorado,
right.
Arizona,
Yeah.
New Mexico, Colorado.
Yeah.
Yes, go ahead.
I was right there in Shiprock, New Mexico. You could put, you know, your feet and your hands right there. That was right up the street from me. That's correct. So I did that for 2 years. Then I actually then transitioned to the CDC, and that's how I got to Chicago. I was the Epidemic Intelligence Service Officer for the Illinois Department of Public Health, and we were stationed here in Chicago. This was 2002 to 2004, and did a lot of outbreak investigations, did some surveillance in HIV. That's my position here now, the Senior Director for HIV Services for Cook County Health. And in 2003, we had SARS, right? That was the original SARS in 2003. Did not hit the home front, but we were on the lookout. We were on surveillance.
All right, now just a second. SARS is a coronavirus, is that right?
And SARS is the coronavirus, right? So we have had coronavirus infections for hundreds and perhaps thousands of years. These are common cold viruses, but this was a virus that actually jumped from the animal world. We call that a zoonotic transmission. So it jumps from the animal world into humans where we have no immunity. And so we learned about how much of a lethal virus this could be from this coronavirus type family back in 2003 from the original SARS. And so we were tracking that. There were outbreaks, of course, in Asia, in Hong Kong, in Canada. Fortunately, it did not get to us. But then as we fast forward, you know, here, 2019, late 2019, early 2020, now we have SARS-CoV-2, which is COVID-19.
All right, so you worked in the first big international outbreak of SARS in 2003, and now you've been working on the COVID-19 variant of the coronavirus to try to figure out how we can treat patients.
That's correct. Because right now, of course, we have, you know, over 36 million now that are infected here in the United States. You know, we have
just a second. Now, so we have a population of about 330 million. So more than 10% of our people have been infected.
Known infections.
Known infections.
It's probably even greater than that. That's correct.
Because a lot of people are asymptomatic. That is, they don't exhibit any symptoms, but they nonetheless have the disease.
They can have, correct, either asymptomatic disease, mild disease, or they don't even get tested. And we know that for every person that is infected, they can transmit to 2 to 3 other persons, very highly transmissible. So that's how SARS-CoV-2 or COVID-19 took off here in the United States. We had our first trickle of cases in January of 2020, and then our first surge, which we really experienced in late February, March, April, in through May. That's the time when our hospitals were becoming overwhelmed. That was the time when we desperately needed new therapeutics and new measures of hopefully prevention. And that's what we experienced here at Stroger Hospital, many of the hospitals here in Cook County.
During that first wave, I know that half of our patients in the hospital were COVID-19 patients. So when you're talking about being overwhelmed, it was a pretty significant number of folks coming into our hospitals, not just Stroger Hospital, but our hospitals all across the county.
That's correct. At that time, the CDC had a test. We had to get permission to test people. We couldn't test everybody. They had to fit a certain symptom category.
Profile.
A certain degree of illness, you know, whether they have pneumonia or being on oxygen. And not everybody fit that profile. And yet, as you said, some people would have maybe more mild to moderate disease, still transmissible, still could get very sick. Most people can get very sick in the second week. So with early symptoms, sometimes we don't recognize that as COVID-19. We had a difficult time testing people. And so even among those that were in our hospitals were being overwhelmed. We could not test everybody, but we needed to treat everybody as if they had COVID-19 because we knew the risk for transmission not only to the house staff, but to family members, to visitors. So it was really all hands on deck at the hospital at that time. It was almost all COVID-19, and we really had to restructure our hospital system to address that surge.
So that means personal protective equipment for everybody in our health and hospital systems and no visitors, as I recall.
Right.
So we took all kinds of precautions to try to limit the spread of the disease.
Absolutely. Yeah. And that's the time when we did drug discovery too. We didn't have any therapeutics against COVID-19. We sort of reached into the deep vault of repurposed drugs to see what would work for COVID-19. And we had a large trial for remdesivir. That was a sort of a repurposed drug. It was first used in Ebola. Again, another one of those, as I call it, zoonotic diseases.
Now just stop for just a minute.
Yeah,
okay.
Sure.
So repurposing therapeutics, that means finding drugs and using them for a different purpose, to treat a different disease, right?
That's correct.
All right,
That's correct.
All right, now tell us about how this drug was used to treat Ebola. And Ebola is a disease that we've seen sporadic outbursts in Africa, right?
That's correct. And there's been some large outbreaks of Ebola in Africa. We are also on the lookout, certainly here in the United States. And in 2014, 2015, we did find some Ebola here. And so this drug was actually used for Ebola patients. It didn't quite work as well for Ebola patients, but we had a lot of experience with this drug, and we had a lot of experience in how to take this as a pill, how to take this as an infusion, what sort of dose we could use. And so we really rapidly then took that experience for remdesivir from the previous, let's say, 5 years, and then put this into clinical trials rapidly into hospitals, into very sick patients. And we discovered that about a third of the patients actually got better much quicker if they got remdesivir versus if they got no drug at all.
Okay, so you infuse the person. That means you put it right into their bloodstream as opposed to giving them a pill, right?
That's correct.
Okay, and a third of the patients, so 1 out of 3, got better as a result of having the drug.
They got out of the hospital much more quickly. That's correct.
Okay.
Yeah.
All right. So that's one way that we learned to treat people who had COVID-19. Let's back up. Let's back up just a little bit here. So we know that both Ebola and COVID-19 are what we call zoonotic diseases. Okay, they jumped from animals to human beings. Is there anything that we can do to mitigate the likelihood that we will see more diseases like Ebola and SARS and COVID-19 that jump from animals to us?
Yeah, very important. How do we prevent the next pandemic? We have 7.7 billion humans here roaming the earth. I mean, this is a sort of an unprecedented type of force where we've driven in so many different places. Our ecologic footprint has now invaded so much of territories that have been sort of isolated to certain animals in rainforests. And here we come in full circle, right? I mean, back in 1990, I was talking to a gentleman about the deforestation in the Dominican Republic, and I got into public health. But where does it all start now? How do we actually prevent the pandemic on a public health side? Well, it really comes down to protecting our forests, protecting I would say the edge areas of where these animals and humans connect. And so if we're going in and there's habitat destruction and then animals are displaced or humans move in, we have more contact with humans and animals. We have no immunity to some of these viruses that these animals are carrying. So that's one factor that we need to be very mindful of, the habitats that these animals have, that these viruses can circulate within these animals. We need to be aware of those viruses. We need to go out there. We need to sample all the animals, identify those viruses as best we can, bring them back into our labs, and then try to make vaccines out of those. So that's one connection with destruction of these forested areas and our ability to go in and discover these viruses and use technology to build prevention. The other factor is what's called a dilution effect. There's 3 factors. I'm going to give you 3 factors, okay?
Okay, so just a second. One is habitat destruction. That's correct. As we move into the rainforests or the jungles or areas where humans have not historically, at least for a long time, been present, we come into contact with animals who may carry diseases that we are not immune to. Okay?
That's correct. Let's take an example. That's one. Bats. Bats comprise 20% of all mammals, an immense population. And bats carry all sorts of viruses that don't really make them sick, but can certainly make humans sick. We've seen that. We've seen that with Ebola. We've seen that perhaps with different types of coronaviruses that can jump from bat to another animal and then to us. We've seen that with so many other viruses. And so the second factor actually then is that when you have this type of incursion into these ecological spaces that a vast variety of animals have thrived in, when we do that, we constrain the types of animals that can live in those areas. And if we constrain that diversity of animals, then those animals can just be a single point for viruses to jump to humans, rather than animals to transmit to other animals and have a sort of asymptomatic wave of transmission among animals rather than jumping to humans. So that's called the dilution effect. We dilute down the diversity of animals, and by doing that, we leave ourselves vulnerable to that direct transmission, that direct what we call spillover effect or spillover event from animals to humans. And then the final factor
just a second. So
Sure.
If you reduce biodiversity, you also increase the likelihood that diseases will jump from other mammals to us.
That's correct.
Okay.
That's correct. All right. And then the third factor is international travel. We can go really anywhere, right? in a matter of hours. We can have again, if you are carrying a viral infection and you're asymptomatic and you get on a plane and you go to Europe or you go to the United States, at some point, perhaps in a couple of days, you may be symptomatic. Maybe nobody's checking you for any of these exotic types of diseases or infections. And then that's the way it can spread into our populations here in our communities. And so the transportation that we've set up, both by, let's say, extensive highways in the developing world, as well as air travel, this really lends itself to potential widespread transmission of these types of emerging infections that then can develop into a pandemic in a vulnerable population that has no pre-existing immunity.
All right, so habitat destruction, reduction of biodiversity, and international travel and migration.
That's correct. And so what we need, so how do we address that? One, we need international networks to actually do surveillance for these types of infections. As I mentioned, we need to go out into these areas, discover these viruses, bring them back, sequence them. That's the way we got to the COVID-19 vaccine. We were able to sequence the virus quite rapidly, understand all the genetic material. This goes back to some of my work in molecular biology, and then put that into a vaccine. So we need an international commitment. We need to work with international bodies. We should not be isolated here. We need to work with the WHO and other international organizations. And we need that as a long-term commitment.
So one of the terrible things that President Trump did was take us out of the World Health Organization. Thank God President Biden has returned us. But we need international cooperation to look at animal populations in the wild, to get samples of the diseases they might have, and then to bring them back to our labs and try to sequence them and find vaccines for them. Is that what you're saying?
That's what I'm saying, and the depoliticization of that is very important. We've talked.
What do you mean by depoliticization?
Depoliticization. So that means, you mentioned the former administration, right? And now you've mentioned the new administration. So that's where we need to set politics aside, and we need to work as a global community in order to protect ourselves really on an international basis. And these early surveillance systems, when this happens in certain countries, we all need to be aware of that. We all need to be part of this network so we can act rapidly to put the pieces in place to prevent further outward transmission.
Okay. All right. We've talked a lot about the origin of pandemics and what we might do collectively in the world to deal with them. What are we doing now in Cook County to address the pandemic?
Well, so before vaccination, it was very important that we practiced what we call mitigation, meaning how can we prevent ourselves without the benefit of these very, very potent and important vaccines. And that was when we understood the transmission patterns. We understood that if we kept our social distance, if we avoided large gatherings, if we were in a group that we stayed 6 feet apart, if we wore our mask, very effective. Masking is so effective. And then we practiced hand hygiene, washing our hands using the alcohol hand gel. That would prevent transmission to a great extent. So that's what we did, and that's so that's from a public health standpoint, we were very much out in front that we needed to put those measures in place to help protect people until the vaccines were on their way.
All right, so just a second.
Yeah.
Transmission patterns just means how you get the disease, right?
How they get to yeah. This is basically a respiratory disease, as I mentioned. We talk about
and respiratory just means you breathe it in.
You breathe it in, yeah.
Okay.
And you can breathe it in, but it needs to hit some part of the respiratory tissue, okay? And the respiratory tissue you have basically in your mouth, down into your throat. You can have it in your nose. There's actually some tissue even in the eye linings. That's why sometimes we wear facial shields. So we need to protect that area. And so for everybody, the masks were very important. For healthcare workers, the eye protection is very important, especially with very sick patients. Very sick patients have higher amounts of virus that can transmit to others. And again, the way we look at, let's say, the force of transmission, for every one person that's infected, they can transmit to 2 to 3 other persons. Very transmissible. That's why we're seeing these 36 million cases and more, because we're very vulnerable. It was highly transmissible, highly contagious, and so the goal to really stop the epidemic is to bring that transmission rate less than 1. So if every person who has COVID cannot transmit to one person, that means that transmission rate is less than 1 reproductive rate. That's the way we can stop the epidemic.
All right.
And how do you do that?
We've got vaccines. Tell us about the vaccines.
So the vaccines. So what a remarkable story for vaccines. Operation Warp Speed took off in March. We had that genetic sequence in January that was posted internationally, and with an unprecedented collaboration among pharmaceutical companies, government, and other resources, we were able to get this type of genetic material into a vaccine called an mRNA vaccine in March, where we first studied it for safety. And then we actually got it into very large trials in July. And after we enrolled in each of these trials, more than 30,000 persons, and the trials are set up. These are standard trials. Half the people get the vaccine, half the people get placebo. Then you let nature take its course. You see who's going to have infection, who's not, do the calculations, see how effective that vaccine is. We knew in November how effective those vaccines were, almost 95% effective in protecting against symptomatic disease. And then we moved again very rapidly to license these vaccines with a early use authorization. And this allowed us then to get the shots into arms in mid-December. Safety was very important, and we also waited at least 2 months after half the people in these trials had received their second dose of the vaccine to know that these were very safe vaccines. So the effectiveness of the vaccine we knew, the safety we knew, and we were able to then get this into arms in December. All right, so here in Cook County, over 1 million doses. Okay.
Just a second. Cook County has 5.2 million people. Some of them are children, however, and children are presently ineligible for the vaccine. Go ahead.
Right. So over 1 million doses have been administered here in Cook County so far. And that's among adults, right? 18 and above. Pfizer is 16 and above. So there are some 16 and 17-year-olds that have been vaccinated. 44% in Cook County have gotten at least 1 dose. 27% have gotten a full completion. And then how does this work actually in the real world? We saw how it worked in the clinical trials. But just last week, the CDC released information among those that were hospitalized with COVID from January up until late March. If you took a look at those that received the full series, 2-dose series of these vaccines, 94% were protected against COVID-19. If they received 1 dose, it was 64%. So now we know, almost 6 months after we introduced these vaccines, we know that they work here as we live our lives and as we roll out these vaccines. So it's very important that virtually almost everybody, you mentioned not yet for kids. We will get this vaccine next week for 12 to 15-year-olds for Pfizer. And then later in the summer, we're going to go down to 6 years of age. But right now, it's very important that we all get vaccinated to build up what we call herd immunity.
What does herd immunity mean?
Calculations.
What does herd immunity mean?
Herd immunity, right. Comes back to those calculations. Remember how I said that that right now the virus can transmit if you don't have any immunity. If one person's infected, it can transmit to 2 or 3 people. Well, the way to get that down is that if you knock out that transmission to 2 or 3 people, you get it under 1. You need to vaccinate, let's say, 65 to 70%, right? So herd immunity means that once we get, let's say, 70% immune, then we can stop that transmission. That's going to put the stop to the transmission. So that's herd immunity. As a herd population, we know what a herd is. A herd of animals, right?
Group
moving together. They're moving together. So we need to move together with herd immunity at least 70%, and we can gain that primarily through this effective vaccination. Some people, again, after they've been infected, will have some post-infectious immunity, and it may last 6 months. It may last less than that. So the best strategy is to get vaccinated. Vaccination is almost the guarantee for immunity. Again, those numbers, that 95%, that's breathtaking to me.
All right. If we're vaccinated, should we still be wearing masks and washing our hands and watching our distance?
So we now have a better understanding that as more of us are vaccinated, that those types of measures, we can, perhaps liberate ourselves to a certain degree. We know that if you're outside and you're among vaccinated people, that you don't need to wear the mask. We know that indoor transmission is 20 times more powerful than outdoor transmission of SARS-CoV-2. So as more of us get vaccinated, we will see some relaxation in these measures. Indoors still very important. We still don't, we don't even have at least 50% vaccinated, right? And we don't know if who you're around indoors, if they're vaccinated or not. If you're around family members and they're all vaccinated, that's fine. We can lose the mask. But if you're in a certain place like a restaurant, indoors, we're still going to need to wear masks until we get to that herd immunity, until 70% or over. That's probably going to be sometime later in the summer.
All right. Is there any one thing you want to leave our viewers with today?
So I really appreciate this opportunity. And I know that you and I have talked almost, we see each other maybe about once a month, right, in certain events for vaccination. And I know that, your skills as a teacher, you've been able to synthesize what we've talked about here. And I really appreciate that. I would say it just comes down to a very simple message. We want to, how desperately do we want to see, the end of COVID, to get to the other side of COVID? And it's a matter of protecting us, protecting our loved ones, and protecting our community. And we can really do that, I believe, with vaccination. That's where we need to be right now. We have so many opportunities for vaccination now, so many options, walk-in opportunities, mass vaccination sites. Talk to your doctor, talk to your friends and family about their experiences with vaccinations. That would be my message now, that to get to the other side, we need to be protected, and the best way to do that is through vaccination.
Again, thank you, Dr. Huhn, for joining us today. I'm grateful for your insights and your good work. And thank you all for joining us. We'll see you next time for Health Hour.
Thank you.